Good evening, good morning, good afternoon, everyone. Uh, this is Dr. Milind Jambaki. I am the chair for the WFPICCS Education Committee, and today I have with me my colleagues from the Education Committee, Dr. Farhan Sheikh, Dr. Michael Canry, Dr. Abdul Rahman, and Georgina Pizzolas. And it's my honor to have Dr. Martin Kneyber today for the very first and the inaugural session of our WFPICCS Pediatric Respiratory Critical Care series, which we are starting from today. And this is going to be a monthly educational program online. And we are planning to have some great lectures from the experts all around the world going forward. So without wasting much time, I would like to just tell you briefly about the idea behind this pediatric critical care or respiratory critical care series. So it was an idea by this subcommittee of the PICCS Education Committee, wherein Dr. Farhan, Dr. Michael, Dr. Abdul Rahman, and Georgina, we all conceptualized this idea. And Dr. Farhan has been very instrumental and helpful in propagating respiratory critical care medicine in India. And it was his idea as well. And then we thought, why not make it a global event and a monthly global event so that it will help a lot of people who treat sick children around the world. So the first topic for this is breath by breath, the real science of gas exchange. And we have with us Dr. Martin Kneyber for this. I would like to take a minute to quickly tell about Dr. Farhan, Dr. Michael, Dr. Abdul, and Georgina, and then I will hand it over to Dr. Farhan to introduce our speaker. So Dr. Farhan is a senior faculty at various national and international platforms for pediatric critical care medicine, and he is a very good teacher and loved by many for his teachings in pediatric critical care medicine, and he does a lot of work in pediatric ventilation, shock, and respiratory critical care medicine. He is the lead pediatric intensivist at Rainbow Children's Hospital, Hyderabad at Banjara Hills branch. And Dr. Michael Canary is an associate professor of pediatrics at Yale School of Medicine and an attending physician in the pediatric intensive care unit at Yale New Haven Children's Hospital. He is a full-time clinician, educator with a strong interest in expanding critical care capacity in low-income country settings, and is involved in many academic activities around. Dr. Abdul Rahman is a PICU consultant at Ahmadi Hospital PICU in Kuwait. And during COVID-19 pandemic, he has developed Kuwait's resource management system and command center, and has also established a simulation program for pediatric critical care fellowship program there. And Georgina is a senior physiotherapist in PICU at Queensland Children's Hospital, Brisbane, Australia, with extensive experience in pediatric critical care, acute respiratory care, physiotherapy, and multidisciplinary education. She has been active for the WFPICCS community for several years, contributing in various capacities. And myself, Dr. Milind Jambaki, I have been associated with WFPICCS since last 4.5 years. I was the Asia lead for the WFPICCS World PICU Awareness Committee, which was the inaugural program started by WFPICCS 4 years ago. And I've been working in various capacities for WFPICCS Education Committee, initially as a member, then I was the vice chair for the Education Committee for the last couple of years, along with Dr. Tracy Walbrink, who was the chair for the last 2 years. And I have taken over as the chair for the Education Committee this year. So this is our inaugural session, and I would like to hand it over to Dr. Farhan Sheikh, sir, for the further introduction of Dr. Martin Kneyber.
Thank you so much, Dr. Milind. So, good evening and good morning and good afternoon to everybody in the world. It is my great honor and privilege to introduce Dr. Martin Kneyber. Dr. Martin Kneyber is the chief of the Division of Pediatric Critical Care Medicine at Beatrix Children's Hospital, University of Medical Center Groningen, the Netherlands. He is also a fellow of American College of Critical Care Medicine. His translational academic interests focus on gaining a better understanding of respiratory physiology and pathophysiology in mechanically ventilated children. His basic research focuses on ventilator-induced lung injury and its relationship with multiple organ system failure. He is the principal investigator for the PAN trial, that is the pediatric ARDS neuromuscular blockade, and the famous, very anticipatory or awaited trial, that is prospect trial, that is prone and oscillation pediatric clinical trial. Dr. Kneyber has published more than 280 scientific papers, written numerous book chapters, and frequently delivers invited lectures and workshops at international critical care conferences. He is currently the past medical president of the European Society of Pediatric and Neonatal Intensive Care, that is EPSNIC, and he is a member of the editorial board of the Pediatric Critical Care Medicine Journal. On a personal note, he has been my mentor for my various research projects, and I can confirm that apart from his exceptional academic achievements, he is an incredibly kind and supportive human being also. We are really fortunate and honored to have him for our inaugural talk for the Pediatric Respiratory Critical Care series lectures. And tonight he will be speaking on the topic, Breathe by Breathe, the real science of gas exchange. So over to Dr. Kneyber, sir.
Thank you, Dr. Van. Thank you very much for your extremely kind words. I feel very humble, and being this the inaugural lecture, I'm very honored by that. I've got invited by the WFPICCS Education Committee, so thank you all. And it puts a lot of pressure on me to deliver, to meet the expectations on a very challenging topic, being the basis of gas exchange. And I'm a physiologist. I like physiology. And it's easy to go into a lot of details, but I will try to take you along the physiology during mechanical ventilation, give you some tips and tricks how you can, when you start titrating your ventilator support, how you monitor it by considering physiology. So I will share my screen. Still visible, the screen? So the real science of gas exchange.
You can't see your screen, sir.
No, I have it. Oh, I forgot to click a button. Sorry, I put on play and I forgot to share. Oh. This is much better.
Yeah.
Now you should see it.
Yes, sir. Yes, you can see.
So the real science of gas exchange. So a little bit heads up. No conflicts of interest to disclose. I forgot to add that slide. Sorry. So a little bit heads up. So as I said, I'm a physiologist. So of course, I do care about evidence-based medicine, but for this topic, it's a bit challenging to talk about evidence-based medicine. And I always teach fellows and residents, so when you test things like mechanical ventilation in a randomized controlled trial, and Dr. Van already cited the prospect trial, you do not test the device, but you test the operator. And I'm convinced that physiology is the basis of practice, at least in the ICU. So I want to refer you to these two books. John West, Respiratory Physiology. It's not a real thick book, but it's a real nice summary of basic essential respiratory physiology. And if you want a little bit more detail, I would refer you to non-supplied respiratory physiology, to more or less landmark books that should be on the bookshelf in your ICU. So before going into a little bit more physiology, so what is respiratory failure? And it's quite easy. It's the things you see in your unit or in your emergency department. You have this patient with respiratory failure, which could originate either from the lung failure, so the lung is sick, or the pump failure, so the patient has normal lungs, but it's the patient, the pump is not working, there is a brain disorder, or there is a mechanical defect, or the patient is fatigued. And classically, we identify these two types. Hypoxemic respiratory failure, which is mainly a primary pulmonary injury with ventilation perfusion mismatch. We'll go into more detail later on. Hypoxia, low to normal CO2 because of an increased respiratory rate. And the type 2 is the hypercapnic respiratory failure, also with a mismatch, but usually defined by hypercapnia. Now, these are two pathways, two types. In all honesty, and I think you would concur with me on that, is we see a combination of both in our units, in our EDs. And there are many, many causes of respiratory failure in children. This is from a textbook, and you can identify disorders in lung and airway disorders, pump failure, respiratory center failure, or even a failure to meet increased metabolic needs, for example, in septic shocks. So there are many underlying causes for the respiratory failure. And there are numerous signs and symptoms of both hypoxia and hypercapnia, depending on the severity of the hypoxia and or the hypercapnia. And they will give you some indication of, okay, am I dealing with a type 1 respiratory failure, or am I dealing with a type 2 respiratory failure, or is it, let's say, a combination of both? And we will not go through all of these, of course, but you can easily read them, that with increasing severity, the severity of the symptoms is becoming stronger, leading ultimately to coma and even respiratory arrest. Now, this is what we see in the ED or in the unit. So this is a patient with a respiratory failure. The chest film shows you bilateral consolidations. So we would say this is an ARDS. Lots of loss of lung aeration. And if you have CT scan available and you would do CT scanning in this patient, you typically see this. So in the dependent zones, lots of collapse, lots of flooding, lots of edema, lots of debris. Very challenging to open up these parts of the lungs. In the more ventral parts, the non-dependent lung regions, fully aerated lung tissue, even hyperated lung tissue, and then a very small limited zone, which was denoted by Gattinoni as the baby lung. So we put a patient on the ventilator. And if you would really boil it down and keep it simple, you would just say, okay, ventilation is about inflate the balloon and keep the balloon inflated. But how much inflation pressure, how much inflation volume, how do we keep it inflated? What do we need to do to improve the gas exchange that is being impaired in our patient? And there is a lot which you can set on your ventilator, and all have an effect on ultimately the CO2 and the oxygen content of the blood. It's the pressures, it's the tidal volume, it's the timing of inspiration, expiration, it's the flow. All these things you have to keep in mind and you have to address at the bedside. But when setting individual parameters or when evaluating combinations of parameters, you need to know, okay, but what is causing hypercapnia in this patient? What is causing hypoxia in this patient? And I think it's important to discriminate between hypoxia and hypoxemia. I on purpose called it hypoxia, but in fact, hypoxia is actually a reduced oxygen delivery to the tissues, not issues, sorry, the T fell to tissues. So, and this is because of decreased cardiac output or anemia or CO poisoning. What we are mainly dealing with is hypoxemia, which is actually a reduced partial pressure of oxygen in the blood. So there is oxygen coming, but for some reason we can't get enough in the blood, so the PO2 is actually low, either by various causes. And then ischemia is a reduced blood flow. So we go through from a reduced delivery to a reduced content to a reduced blood flow. And we will mainly focus on these two. So the basic function of the respiratory system, and now we start off first with some physiology, is to supply oxygen to and remove CO2 from the body. That's what we have learned in medical school during our physiology classes. And there are various steps necessary. So we have a gas exchange between the atmosphere and the alveolus, diffusion of gases along the alveolar capillary membrane, transportation of gases in blood, so lung to the blood, and then diffusion from the blood into the peripheral tissue. And this is the ideal world. I think if you either whatever textbook of physiology you open, if it's Byrne and Levy or it's Guyton, these are the images you see. So you have a lot of oxygen in atmosphere, it goes into the alveolus, diffusion takes place, and then it's transported from the pulmonary veins to the left side of the heart, and then to the end to the tissues. And from a PO2 of 100 in the capillary pulmonary capillary blood, you go to a PO2 of 40 in the capillaries before it goes to the tissues. And there are a lot of steps and a lot of processes involved from going to this value to ultimately delivery of a PO2 of 1/4 of a PO2 of 40 at capillary level. So this is how it works in a healthy adult. So you have a single lung. This is an alveolus. This is a capillary with a blood flow. The blood flow in an adult is about 5 liters per minute. Tidal volume in adult is about 500 milliliters. Goes into the alveolus, passes the anatomic dead space at a certain rate, resulting in typical alveolar ventilation. But of course, it's important to understand that the oxygen that is out there in the atmosphere, which is going into alveolus, is actually not the one that we see, as you saw in the picture before, at tissue level, but there are various components which contribute already physiologically to a decreased oxygen content. Because in the air, the blood flow moves on, there's a slight drop, then there is mixing at capillary level, then it goes into the pulmonary arteries, then you have diffusion and shunt, and I will explain diffusion and shunt later on. Now, diffusion of gases is a really important concept in getting oxygen from the atmosphere into the blood in the lung and CO2 the other way around. And this diffusion through a tissue seed is dependent on the area. So the larger the area, the better the diffusion. And this we should keep in mind when we want to keep an open lung. The thickness, for example, you can imagine. So with a patient with a severe, let's say, interstitial problem, the thickness increases, or if there is a lot of edema that's stretched on or debris, the thickness increases, so the diffusion becomes less easy. And then, of course, the partial pressures. And what you also note is that the arrow that explains the diffusion of CO2 is much thicker than the arrow that explains the diffusion of the O2. So it means that the diffusion of CO2 is much easier across a membrane than the diffusion of oxygen, even 20 times more easy. So this is important to understand why you can have a patient who is still has hypoxemia because of a low PaO2, but may have in the beginning a low CO2 because of the increased rate and the rapid, easy diffusion across the membrane of CO2. So it's the thickness of the lung that plays a role, but also what plays a role is how fast is the blood moved through the lungs. And again, these are normal physiology pictures. This is not even pathophysiology. So the effective transit time in the presence of a normal alveolar oxygen content, so this is normal one, so it occurs very rapidly. As soon as your diffusion becomes impaired, or even grossly impaired, you need much more time to get enough oxygen uptake. And even in a grossly impaired diffusion, you may not even reach the levels that you see under normal conditions. So this means that if you have a really tachycardic patient, for example, you can imagine that the transit time is too short for a sufficient oxygen uptake, and you need to do something about the tachycardia. This example shows you that it's even more strong if you are in an environment where the atmosphere is low in oxygen. Or, let's say, you have a patient on the ventilator and you forget to turn up the FiO2. Then the oxygen content in the gas that you are giving is too low, and then it takes even more time for a sufficient oxygen uptake. So that's why we want to give sufficient amount of oxygen delivered by the ventilator. So we know how it goes into the lung. We know it takes some time. But then we have to match lung ventilation and lung perfusion. And what I mean perfusion is not the bronchial arteries, but I mean the capillaries. We have the capillaries, they have to take up the oxygen and they have to remove the CO2. And under normal conditions, blood flow completely matches ventilation. So the ventilation perfusion ratio is 1. So ventilation fully matches perfusion. This is under healthy conditions. And I will show you later on conditions where the ventilation perfusion ratio is altered. And what you might remember from your physiology is that this ventilation perfusion is not the same throughout your lung, as we are in an upright position, because gravity plays a really important role. And these are the so-called famous zones of West, zone 1, zone 2, and zone 3. And this is in an upright position, but you can understand that this also takes place when the patient is in supine or in prone position in the bed. So in zone 1, the most upper part of the lung, the alveolar pressure exceeds the arterial pressure and exceeds the venous pressure. So there is mainly ventilation and no perfusion. Whereas in the lowest parts of the lung, the arterial pressure exceeds the venous pressure, but it also exceeds the alveolar pressure. So then this blood flow is dependent on both pressures. And here you have mainly perfusion and not ventilation. And you can imagine if you apply an intervention where you are going to increase your venous pressure really, really much, remember positive and expiratory pressure, potentially you may impair this blood flow and you may further cause ventilation perfusion abnormalities. Well, this is under physiology, and our body has been made so that what's happening over here counter-affects what's happening over here. So overall, you have this ventilation perfusion ratio, which is perfectly mixed. But you may end up in a situation where this is the normal situation. You have ventilation, alveolar oxygen content, alveolar CO2 content, adequate perfusion. But you may end up in a situation where you do have perfusion, but you don't have ventilation. For example, a blocked endotracheal tube. This is where the ventilation perfusion ratio approximates 0, because there is no ventilation, nil, divided by perfusion, it's always nil. So there will be no effect on your your alveolar oxygen content will drop. On the other hand, you may have a situation where there is ventilation, so oxygen comes in, but there is no perfusion, and the VQ ratio will become indefinite. So if you would look in the alveolus, indeed there is enough oxygen, but there is no CO2 because there is no perfusion. And this is in 3 separate conditions. But as you may see, there is a relationship between these conditions. It's happening all over throughout the body. And depending on where you are with your VQ ratio is a difference in the alveolar concentration of O2 and CO2. Here again, we have the no ventilation, but perfusion, which is known as dead space ventilation. Remember this for later on. And this is the shunt, ventilation, but no perfusion. And if we transpose the zones of West on this ventilation perfusion ratio, you see that through wherever the deeper you go into the lung or the lower, the more you go to base of the lung instead of the apex, the change in the VQ ratio with mainly perfusion, but no ventilation. But because it's changed throughout the lung, overall we are fine. Now, we don't have a single alveolus, of course. They're all joined in lung units. And within lung units, you may have the situation where one is a dead space ventilation or a partial dead space ventilation, and in the other lung unit, there is a shunt. And one lung unit, there is normal. And because of these different ventilation perfusion ratios, your oxygen content will change throughout the passage of blood in the capillaries and will give you sufficient oxygen under normal conditions. And this is under normal conditions. Now, what also is important to understand is lung volume. And lung volume has a very strong effect on your pulmonary perfusion. And it's a U-shaped curve. So here we have the lung volume. This is the resistance of the lung vascular resistance. And in the situation where the lung volumes are low, the extra alveolar vessels become compressed. They become smaller, increasing the pulmonary vascular resistance. But on the opposite as well, if you have a high lung volume, you're going to stretch and compress the capillaries. So there is extra alveolar vessels, fine, but the capillaries get compressed and there will be no perfusion. So this U-shaped curve means that there is an optimal zone or a Goldilocks zone where there is a good balance between lung aeration and the lowest vascular resistance. And this concept is not just a concept, but this is the basic concept behind ventilation conventional and high frequency, why we want to keep a lung sufficiently open, because then we know that the perfusion is the best. Now, if we want to translate all of this physiology to what is the cause of hypoxemia, we can look into hypoventilation, we can look into shunting, diffusion limitation, and ventilation perfusion mismatch. So first, the hypoventilation. So here again, I display this cartoon that I showed you in the beginning, which shows you the drop in O2 between atmosphere and at mitochondrial level. And the non-interrupted line represents the perfect condition, the healthy condition. Now, let's say a patient who is hypoventilating, then you see that the oxygen content of the blood is going to drop at hypoventilation. And intuitively, you say, oh, hypoventilation just gives hypercapnia because CO2 doesn't get out. No, it's one of the most important causes of hypoxemia. And hypoventilation in your ventilated patient would be a too low rate, for example, at least a rate that does not match an adequate gas exchange. We know from the whole mechanical power concept that we don't want to use a too high rate, but at least we should have a rate which gives us an adequate oxygen uptake. So the alveolar PO2, we can calculate it using this formula with the barometric pressure and the water pressure, and then the respiratory quotient. And this quotient, this number is because CO2 and O2 are all within one balloon. And if one gas goes up, the other one has to go down. So this is the RQ. You can calculate the alveolar CO2 using this formula. So all in all, it's a balance of removal and replenishment. So hypoventilation always leads to a lower PO2 because your rate is too low. You don't offer enough oxygen to the patient. And even if you would put the FR2 up to 0.1, you may still have a low PO2. And it's very nicely showed in this cartoon, and I will guide you through the cartoon. So here you have the alveolar ventilation on the x-axis, and here you have your alveolar PO2, your CO2, and saturation on the y-axis. Now, let's look at the alveolar CO2. So the higher the alveolar ventilation, the lower the alveolar CO2. The lower the alveolar ventilation, so hypoventilation, the lower your alveolar PO2 will be. And your saturation will also drop. So if you want to provide sufficient oxygen to the body, maintain an acceptable alveolar ventilation. Now at alveolar level, under ideal circumstances, the alveolar oxygen pressure mirrors the arterial oxygen pressure, which is determined by the oxygen content, the alveolar oxygen pressure by the content, the quantity of air, the ratio of the alveolar ventilation to perfusion, and the extent to which equilibrium is reached. This is just basic physiology. And again, here you have the formula, you can calculate it. Now our uptake and delivery of oxygen to the tissues depends on the so-called Bohr and Haldane effect. So this is some basic physiology, but let's go through it. So the Bohr effect describes where the affinity for O2 depends on the pH. And I will come back to the oxygen dissociation curve later on. The Haldane effect says that the affinity for CO2 depends on the oxygenation status of the hemoglobin. So on the normal conditions, you have the alveolar, O2 goes in, is being taken up by the red blood cell through this, and then CO2 goes off. So if you have a poorly saturated hemoglobin, so hemoglobin that is low on oxygen content, the release of CO2 is hampered. That's what's called the Haldane effect. And at tissue level, it's the Bohr effect. So you have your saturated hemoglobin, there's exchange, so H plus is taken up, and because the H plus is taken up, the O2 is being delivered. So this is what's constantly going on in our body. And now you understand, and I will show you the oxygen dissociation curve later on, but now you understand the idea behind permissive hypercapnia. Permissive hypercapnia doesn't mean, okay, we accept the CO2, but we say, okay, we limit our pressures, accept the CO2, inherently the pH becomes a drop. And the benefit of that is that your oxygen delivery to the tissue improves because there is more, the pH is lower, hence the release of oxygen is improved. So that might explain one of the benefits of permissive hypercapnia, not only the pressure limitation and not only being injurious to the lung, but also the fact that oxygen is distributed to the tissues more, or released to the tissues more easily. Now let's go back to the shunting. This shunting I showed you in the beginning. So this is the shunt. So you do have ventilation, but you don't have perfusion. And this is shunting. So blood is passing non-ventilated areas. That's actually the true shunt. Now let's go to the oxygen dissociation curve. It has a sigmoid shape, and here you have your PO2, and here you have your percentage of oxygen saturation. Now there is a relationship between the PO2 and your O2, and here's your saturation. And at some point, the relationship is not linear anymore, but it becomes flattened. So this is your typical curve, and you can calculate your oxygen content with this formula. Now, when we have the oxygen dissociation curve, it's affected by your pH and by the temperature of the patients and by the CO2. So a patient who has a lower pH, the curve shifts to the right, and oxygen is released to the tissues more easily. Now for CO2, the story is not that complicated. So you have CO2, 5 to 10% dissolved, mainly it's bound to the carbonate, and it's released through this. What does a body do to increase your CO2 rate, of increased CO2 elimination? It increases the rate, it binds to hemoglobin, and the kidneys increase more ammonium. And now I realize I have to give you one little bit of a clarification. When I showed you the slide where there is ventilation but no perfusion. That is the dead space, of course, because there is a continuous ventilation, but there is no perfusion. And the definition of shunt is blood is passing non-ventilated lung areas. So the cartoon on the left, where you had to stop in the airway, it's the shunt, because you don't have ventilation, you do have perfusion, and the other one is the dead space. It's really important to discriminate those. Sorry for the confusion. Now, the dissociation curve of CO2 more or less shows the same as for oxygen, depending on how well oxygenated the hemoglobin is. And it's very linear. So it's not as strong and not a sigmoid shape as the oxygen dissociation curve. It's more linear and mainly dependent on the oxygen and the venous PO2, and not necessarily the pH like the oxygen dissociation curve does. Now, and the final cause is ventilation perfusion mismatch. So here we go again. So here's Rayleigh-Long model. Unfortunately, it's correctly displayed. So the shunt, so you cannot ventilate, but you do perfuse. The dead space, you can ventilate, but you cannot perfuse. And all this has an effect on your venous CO2 and your arterial CO2. This is what is known as alveolar dead space. Alveolar dead space is actually that part of the alveoli that don't contribute to ventilation. This is the airway dead space, which is the airway of the patient, and of course the system, the ETT, the endotracheal tube, and the patient circuit. And both are what we also label as the physiologic dead space. And the physiologic dead space is something we can calculate at the bedside. I will show you later on. So once again, to really underscore, shunt, we cannot ventilate, but we do have blood passing. Dead space, we can ventilate, but we have no blood passing. And this is the normal one. Now, here's again this simple lung model with the different parts. So here we have no ventilation. So this is the shunt. Here we have ventilation, but no perfusion contributing. And all of these different components, this explains why our oxygen dissociation curve has this sigmoid shape. Now, and if you accept high saturations, then you lose the information of the signal. Then you don't get a real strong signal of, okay, what is my PaO2? How well balanced is my dead space versus my shunt in my single lung unit? So there is a strong relationship between gas exchange and ventilation perfusion mismatch. Remember in the beginning where I showed you the cartoon where we had the big knob on one, which completely matches ventilation and perfusion. Now here you see change in the VQ ratio. So this is no ventilation, but we do have perfusion. Lots of ventilation, but we don't have perfusion. And you see the change with the changes in VQ inequality in your arterial CO2 and your arterial O2. Oh, sorry, in your arterial PO2. Now, if we want to assess where the shunt is, a true shunt doesn't respond to 100% oxygen. And so here you have this nice example again. There is ventilation. This is fine, this perfusion. So this means that this will contribute significantly to the PO2. But here we have a poorly perfusion. This is not exposed to the alveolar gas. So this oxygen content in this part of the thing will contribute to this part of the oxidation curve. So if you want to test, okay, do I have a true shunt? If you expose your patient to 100% oxygen and there is no improvement in oxygenation, then you have a true shunt, which, for example, would be, let's say, in a cardiac patient when the lung is fine. But in our patients with lung injury, we have lung units with a normal VQ ratio. We have lung units with a dead space ventilation. We have lung units with a shunt. So increasing their oxygen in the ventilator will improve their oxygen in the blood. Now, a small word about volumes. This is if you were to measure the lung volumes using spirometry, the functional residual capacity, which is the volume that is left in the lung at the end of expiration, our tidal volume, and this is an important volume. Now, the tidal volume in mammals, just one word, and then we forget about tidal volume, is the same whether or not you are a whale or a dog or a mouse. All mammals have a tidal volume which is about 5 to 8 ml per kg ideal body weight. So that's something you can keep in mind at the bedside. So tidal volume, normal breathing fresh gas. The FRC has a very important function because it's the amount of air left behind after normal expiration. And it's the resultant of our chest wall wanting to move out and our lung wanting to move in. That's how it's built. It prevents alveolar collapse. And it functions as an oxygen reservoir. So, of course, with each breath, you bring in fresh oxygen, but your FRC functions as an oxygen reservoir. And that's the basis behind adding PEEP to maintain end expiratory lung volume, to maintain an end expiratory oxygen reservoir. Now, we have to deal with lung injury and we have to deal with gravity in our patients because our patients are supine in their bed. I mean, they're not upright. So there is this superimposed pressure because of the gravity leading to lung collapse in the most dorsal part of the lungs. And this is prominent in normal patients or patients without lung pathology. But as soon as you have some sort of lung injury, and this is ARDS, which is, of course, the most prominent one, the difference between the aerated lung and the non-aerated lung becomes more prominent and becomes stronger the more you go to the dorsal parts because of the superimposed pressure. And this is one of the rationales underlying the concept of prone positioning, because you can imagine that, especially in older patients, in older children and adult patients, the weight of the heart and the mediastinum really pushes on the lung. And if you flip the patient, then the weight is in the dorsal part. So we give positive end expiratory pressure because we want to maintain lung aeration, as you can see in this example. But depending on the superimposed pressure in the lung, you need more positive end expiratory pressure to maintain sufficient lung volume. So in this example, for this patient where a PEEP of 15 centimeters of water was set in the most non-dependent lung zones, it really leads to big lung aeration, maybe even over distension, whereas in the dependent lung zones where there are already collapsed alveoli, this amount of PEEP might not be even enough to give a sufficient amount of lung volume. So this is the basis behind trying to get trying to open up the lung by having PEEP, but at the same time, this PEEP is not uniformly distributed to the lungs and may be detrimental in some parts, beneficial in some parts, and not working in some other parts. So knowing all this, we want to monitor what we are doing with ventilation, and we have all these numbers. We have the arterial O2 or the arterial or capillary CO2. We can calculate an alveolar arterial gradient, an oxygenase index, PF ratio, and we have indicators for ventilation perfusion mismatch. The dead space over tidal volume ratio, the arterial venous dead space fraction. The bracket is gone, but it can easily be calculated. I'll show you later on. Now, what happens if we increase our minute ventilation? We decrease our CO2 in the blood. This is the minute ventilation. This is the CO2. So the lower the rate, the lower the minute ventilation, the higher the CO2. So we can easily monitor our effect of changing our rate in our patients. But for PO2, it's really, really complicated because the PO2, so the arterial oxygen in the blood, partial pressure, not only depends on how much oxygen we give, the FiO2, but also depends on the percentage of shunt. And here in this cartoon, you see the percentage of shunt, 10%, 20%, 30% to 50% shunt. And then depending on how much oxygen you give, you can get an improvement in your arterial PO2. And as soon as you have 30 to 50% shunt, despite the fact that you may give 60 or 80%, there is a little change in PO2. So you can use also then at the bedside, increase FiO2, see what happens with the PO2 to get a rough estimate of how much shunt is going on. But it is really important to consider. So there is another clear relationship with PO2 and how bad the lung is, because it's highly affected by the degree of shunting. And of course, the drop in cardiac output may also result in lower arterial O2. That's the ischemia. So there might be sufficient O2, but the cardiac output doesn't meet the demands. Now, you can calculate this, and this is a mathematical study, and we are repeating it in children right now, what the effect is of various degrees of shunt, various degrees of FiO2, and various degrees of arterial venous difference in oxygen at a similar shunt level. Now look at this above panel. So here we have 3 different degrees of shunt, 1%, 20%, 60%. The difference in arterial venous O2 is 5, is kept constant. FiO2 on the x-axis and the PF ratio on the y. And you see if there's really no shunt, there seems to be a very nice relationship between FiO2 and the PF ratio. But as soon as the shunt increases, it either has this U shape or it drops. So on the outside, if you calculate your PF ratio, but it doesn't give you a really strong indicator for how bad the lung is injured, because shunting plays an important confounding role. So I'm not saying don't calculate the PF ratio, but please keep in mind when you interpret this number that you have to have some idea of the shunt fraction that confounds the value. And that's why most people calculate the alveolar arterial gradient. Remember this cartoon from the beginning, the drop in oxygen content and where you are at either at alveolar level or at tissue level. And various factors determine the change in, how much have I put in my alveolus and what do we actually see in the blood? So what's the gradient? The alveolar O2 minus the PaO2. And the Biden gradient, especially when there is a normal oxygen content in the alveolus, but low blood, is mainly because of an impaired gas exchange. If you have a low PaO2 with a reduced alveolar PaO2, then you have ventilation problems. So if the AA gradient increases and you are sure that you have a sufficient supply of oxygen through your ventilator, then it gives you an impaired gas exchange, and it helps you to understand there might be a problem in diffusion or there might be a problem in the ventilation perfusion. So this does require some calculation, and it does require an arterial line because you need the arterial oxygen pressure. But it's really important to understand all this because hypoxemia, it's a hallmark of ARDS. I remember the paper in 1967 from David Eisbach where he described ARDS, and the adults heavily rely on the PF ratio using the PaO2. In pediatrics, this is the PALIC-1 definition, but now, of course, we have the PALIC-2, where we have oxygenation index as a metric of oxygen severity, which also heavily rely on the PaO2. And now even in the new revised version where we have only 2 categories, we still have the OI in. So we still need an invasive metric of oxygenation. Now the PF ratio, you can calculate it very easily. PaO2 divided by FO2. The OI is mean airway pressure times FO2 times 100 divided by your PaO2. So the difference between the OI and the PF ratio is that the OI has the same drawbacks as the PF ratio. So it's not affected by barometric pressure, markedly dependent on oxygen and on the extraction, but it does take the intensity of ventilation into account. And the adults are maybe a little bit leaning towards getting the OI now as well. If you don't have an indwelling arterial line, you can have some idea of how well your patient is oxygenating, because in the oxygen saturation index, the PaO2 is substituted by the transcutaneous measured oxygen saturation. But remember the oxygen dissociation curve, you can only use this formula if you have an SpO2 below 98%, if you are on the linear part of your oxygen dissociation curve. So PF and OI help you at the bedside, help you stratify severity. There may be some prognostic value, especially in the OI, but remember, they're heavily reliant on PaO2, and the PaO2 is affected by the degree of shunt and how much oxygen you give. And they have different effects. So here we have one patient. Chest radiograph, we begin. We have PEEP of 5, PaO2 of 60, FO2 of 0.6, MAP of 8, giving us a PF ratio of 100. So we would say, okay, this patient has severe ARDS. Now we're going to treat the patient, PEEP 14, PaO2 increases, FO2 has decreased a little bit, but the MAP is significantly higher, giving a PF ratio of 240. So we would say, oh, wow, this patient no longer has severe ARDS, but the patient has mild ARDS. But if you would calculate the oxygenation index with these variables, they would stay the same. So this patient in the old classification would have moderate ARDS. It still has moderate ARDS because the degree of ventilation is taken into account. So the drawback of PF ratio is you can make the numbers look really well and you can label the patients really like they have improved, but in fact, they might not have improved at all. Now, the indwelling arterial line, that's a big issue. In small children, the availability across the globe. So since it's the gold standard PF ratio, you can use SpO2-based metrics, again, if your saturation is below 98%, and they really correlate well. So if you take this into account, and if you apply in your unit the rule that 97 is the new 100, and that's, for example, what we have done, we don't want to see a saturation above 97% on the patient monitor, then we can use the saturation and calculate the OSI instead of the OI, and we have a non-invasive metric for oxygenation readily available. And Robbie Kamani, my close friend from LA and a really stellar investigator and clinician, in one of his studies, he explored this and showed a very good correlation between the OSI and the OI and the SF ratio and the PF ratio. So really supporting the use of non-invasive metrics for classifying oxidation severity if you don't have invasive metrics available at the bedside. Now, and then lastly, before we try to wrap up, I showed you the dead space. So there is ventilation, but there is no perfusion. So the dead space. We can calculate dead space at the bedside. And remember Riley's model, and you can ask why. Okay, is it relevant? Well, first, let's understand how you can calculate it. So the original Bohr formula from, I think, more than 100 years ago or 150 years ago was the difference between the alveolar CO2 minus the end-tidal CO2 divided by the alveolar CO2. But it requires measuring alveolar CO2, not easy at the bedside. So Enghoff made a modification and he substituted the alveolar CO2 pressure by the arterial CO2 pressure, or you could do capillary. This gives you the VD/VT. And you see here the difference in these two approaches from a tracing. So it helps you to assess the dead space, so the visual dead space over the tidal volume as a marker for lung perfusion. And it's a really important variable and a much ignored variable. But way back in 1975, Peter Suter showed that, for example, during a PEEP titration, what best predicted optimal PEEP was not oxygenation or those kind of metrics, but in fact only the VD/VT, so the dead space ratio. The dead space was the lowest in patients because cardiac output improved and the compliance had improved also with higher PEEP. So it may help you identify the best level of PEEP. And because he showed this, because when he decreased PEEP or increased PEEP, there was a change in dead space and a change in cardiac output. So it's a very simple tool, or you can calculate it at the bedside to get an idea of how much dead space is going on and how much VQ mismatch is going on. Now, from the group of Robert Kamani, this is Anup Bala's work. They calculated the arteriovenous difference in CO2, so as shunt fraction, as an indicator for shunt. Arterial CO2 minus end tidal divided by arterial CO2, found that it very nicely discriminated survivors versus non-survivors, discriminated the part severity strata, and now they're doing studies if it's helpful for guiding therapy, like interventions like nitric oxide or PEEP titration. But this is also a very easy, accessible, and cheap tool at the bedside to get an idea of shunt. So you understand the whole concept of ventilation, perfusion, and shunting, but it's very difficult to measure arterial oxygen content, capillary oxygen content, venous oxygen content. You need all sorts of lines. This is a fairly non-invasive estimate of the degree of shunt. So after these, almost 45 minutes, 50 minutes, I've taken you along the way of, giving you some insights in the basic respiratory physiology, which I think is vital when you go into your unit and manage ventilated patients or patients with respiratory distress. So try to understand the physiology of the patient you are seeing. What kind of clinical phenotype do we see? Is what kind of type of respiratory failure and what kind of type of lung disorder? Is it a restrictive problem, or is it an obstructive problem, or is it a pump problem? And monitor gas exchange by whatever means you have, and really then define the problem, because then you can pick out, okay, I'm going to go this pathway and I can evaluate it, or I'm going to use this intervention and evaluate it. But please keep in mind that you have to individually titrate your approach to solve the problem to what the patient is having. Always ask yourself, okay, what is this patient having and what does this patient need at this particular moment of time in the disease trajectory? And it changes over time. It changes over days, it changes over hours. And when the patient comes in, what the patient then needs is completely different from what the patient needs later on. And physiology and this basic respiratory physiology will help you in supporting your patients. And with that, I would like to thank you very much for your attention. And again, very humbled and honored to be part of this fantastic WFPICCS series and giving you the inaugural talk. Please do not hesitate to reach out to me either through Blue Sky or send me an email if you have any questions or whatever. Happy to share the slides also. And with that, I give the floor back to the chairpersons. Thank you.
Thank you so much, Dr. Martin. It was really a wonderful lecture, and as always, Dr. Martin has been a very good teacher, and what a big start and what a good start for our series. So with this, I would like to hand it over to Dr. Abdul Rahman and Dr. Michael, my colleagues, and Georgina, because we have a few questions in the chat box, and if they have themselves any questions, I would request Dr. Michael and Dr. Abdul to take over.
Thank you, Milan. Thank you, Dr. Martin. Thank you for the detailed lecture regarding explanation of the science of the gas exchange. So the floor is open for anyone. Just post your question in the chat. We'll read it for Dr. Martin. So there is a question raised initially at the beginning regarding PEEP5 versus PEEP14, that X-ray that you showed. In what situation we tend to use which exactly? So do you think that the PEEP5 is going to be optimal, or are we giving it an over-distending the lung comparing to a PEEP14 when there is the same thing? Are we over-distending the lung, or is it appropriate for recruiting and doing the job?
Yeah, no, that's an amazing question. And I use that slide as an example to show you how the PF changes and the OI doesn't change. But if you bring that to the question, okay, how much PEEP do I need to give? You can talk about PEEP setting for hours. It's one of the most heavily debated topics in ventilation. We do need PEEP to maintain lung aeration because we have our patients sedated. We have the effect of gravity. We have in our lungs physiology a critical closing pressure of our lungs there. Our alveoli stay open also. But it's very difficult to find a balance between overdistension and collapsed lung. And there are several tools. The most famous are the PEEP FR2 tables by the ArtsNet, which help you, okay, for a particular FI2, I should set a particular PEEP. But the problem is that it ignores the fact that not all patients are the same. Some patients with diffuse ARDS probably, or diffuse lung injury, probably benefit from a higher PEEP. But patients with a, let's say, focal lung problem causing a decreased PF ratio do not benefit from the same amount of PEEP as one with diffuse, because then you overdistend the already overdistended lungs. So we really need tools to help us titrate the level of PEEP. So and it's much, the tables are much debated because none of the tables actually have shown improved outcome so far. There is the discussion of esophageal pressure manometry, where you measure the pressure in the lower third part of the esophagus as a proxy for the pleural pressure, and try to maintain an esophageal pressure a little bit above, PEEP a little bit above the esophageal pressure to make sure that the pressure inside the lung is higher than the pressure outside the lung. Physiologically, that works. Daniel Telmore has shown that, but it doesn't improve outcome. So what we are now looking for is, can we use imaging techniques like lung ultrasound or impedance tomography to help us visualize the balance between lung overdistension and lung recruitment when you titrate the level of PEEP. If you don't have all these tools, we usually do it by oxygen saturation, transcutaneous measure oxygen saturation. But well, we do understand that there's not a really good correlation between how well the lung is aerated and the oxygen content, also because of the shunt. So we need additional tools for that. So it's an amazing question. It's very difficult to answer. There's no magic bullet for, okay, this is the best PEEP for this patient. And if you would keep it simple, what do we teach the fellows and the residents? Okay, set your PEEP so that you can balance oxygenation and hemodynamics. Make sure that you have acceptable hemodynamics, acceptable oxygenation. If you have an indwelling arterial line, try to measure the venous saturation, preferably in a line from above, so that you can have an estimate of central venous. And as long as there's no idea, okay, there's an oxygen debt, so lactate didn't increase or your venous sets are not too low, then accepting a little bit lower oxygenation to make sure that hemodynamics are fine helps you along the way. And in some patients, a PEEP of 5 gives a good balance between oxygenated hemodynamics, and in other patients, a PEEP of 10 or a PEEP of 15 give a patient that balance oxygenation hemodynamics. And for example, to show you how challenging it is, when we put patients on the oscillator with really severe ARDS, sometimes we have to go up to pressures as high as 50 centimeters of water to really open up the lung. So that's, yeah.
will answer. So I'll leave the mic to my colleague, Dr. Michael, for the second question.
Thank you, Kneyber, for attempting to distill these complex concepts into practical terms. We have a question. It's actually a two-part question, but maybe you could discuss how regional VQ heterogeneity and diffusion limitations are affected during pediatric acute lung injury.
Yeah, that's a very good question, and I think we can borrow from what we know from adults. They have done a lot of CT scanning studies, a lot of imaging studies on that matter, and we know that ARDS is mainly a diffuse problem. So you can imagine that there is a heterogeneity in distribution of ventilation perfusion ratios across the lung, and that makes it challenging because if you want to use specific interventions, for example, let's say nitric oxide, where we all think, okay, it's going to help us improve ventilation. But we know nitric oxide goes to the already better ventilated lung parts. So the balance in, for example, such an intervention is that, yes, for sure, you will improve VQ matching in some lung units, but you will also further impair VQ matching in other lung units. And the same goes for PEEP, and that's the whole difficult part of this is with all these concepts and the physiology. We teach it and we learn it from a single lung model, and we understand that there is a difference, but we don't have the best tools yet to really at the bedside understand this heterogeneity in VQ, because we only have the rough estimates, which we either measure in the ventilator or in the blood, but we don't have, let's say, an oxygen sensor that we can place in the distal parts of the lung, and which we can place in the non-dependent parts of the lung, so that we can assess the heterogeneity.
And just to follow up quickly on that one, I know you touched on this, but could you talk briefly about the physiology of proning related to that concept?
Yeah. So the physiology of proning, there are two main rationales for use of proning. Notwithstanding that we don't know yet whether or not we improve outcome. That's what prospect going to show or not. So when you have patients in supine position, the vertebrae are in are dorsal, the heart and the mediastinum is ventral, and that weight pushes on the lung zone, on the lung zones that are in the dorsal parts, so they are prone to collapse. Then you have the gravity, which further puts weight on the lower, on the distal lung parts. Now, if you flip the patient over, the heart and the mediastinum goes to the dorsal parts of the lung because the patient is flipped over. So they don't exert any more weight on the lung tissue, or at least a little bit on the lung tissue, not as much as when the patient is supine. So the superimposed pressure changes, and this improves the distribution of the transpulmonary pressure throughout the lung. So you get a better distribution of how much pressure is needed to open up lung alveoli. And because it gives a more homogeneous distribution of this pressure, and hence a more homogeneous distribution of the volume, the perfusion overall improves. So in supine, you have mainly perfusion in non-aerated lung tissue. The patient is in supine position, the weight, lung collapse, so there's no ventilation, but there is perfusion. But if you flip it over, then all those lung areas stay open, and the perfusion improves. So it's less weight, better perfusion, and better distribution of the pressures.
Perfect. Amazingly answered. So we'll take another question from the chat. We have a bit of a long question. Why is PF ratio removed from Paddock classification of parts? In adults, they still use PF ratio, and in last years during viral pneumonia epidemics, we have seen children on ventilator for bars due to viral pneumonia have non-recruitable lungs and don't need high mean airway pressure, and hence their oxygen index is not very high, and PF ratio seems more reliable in assessing for need for ECMO. So what's your take on that?
Yeah, that's a very good question. I've been involved with PELIC 1 and PELIC 2, and this has been heavily discussed. One of the reasons, and I think a few years before the first PELIC was published, there was a paper by Doug Wilson, Neil Thomas, and Robbie Kamani, where they more or less summarized some of the pediatric versus adult considerations in OI versus PF. One of the reasons was that it's affected by how you set your PEEP. And with the adults, they are not the best in PEEP setting, but we at PEDS do even worse. If you look at, for example, at the PARTY study, which was a study where we evaluated, okay, how are PELIC recommendations implemented? And if you would superimpose the PF of the PEEP FR2 tables from ArtsNet over it, we see that in our units, as soon as the FR2 starts to hit 0.6, we should increase our PEEP, but we don't increase our PEEP. Instead, we are going to increase FR2. And we are going to give lower amounts of PEEP. And all of this affects shunt, and all of this affects the real accuracy of the PF ratio. Adults have the same, but they are better at setting PEEP. They are not as PEEP phobic as we were, and that's a really important reason why we really wanted to have a metric of intensity of ventilation into the consideration. Now, you're right about that. It's about non-recruitable lungs. And we know that, for example, with COVID as well. So you had the discussion about the PF ratio. When we have patients in our unit with viral pneumonia, we calculate the OI, of course, but we simultaneously record the PF ratio to give us some idea of, okay, this might be a non-recruitable lung. But then still, I think even in those patients, although they don't have a real recruitable lung, but you don't need a PEEP of, let's say, 10 or 15, but patients might need a PEEP of 8, but we still tend to use PEEPs of 5 or even 4 because we are afraid of dynamic hyperinflation because of the PEEP level. So it's the main reason, even in these conditions, is our PEEP phobia and the potential confounding effect of giving not enough PEEP to get the best estimate of PF available.
Excellent. I like the word PEEP phobia. We do have that. Really, they try to avoid it, and it might be the answer. Next question, I'll hand it over to Dr. Michael.
Sure. Thank you very much. I know you touched on this, but regarding lung overdistension in PEEP and pediatric ARDS, how actively do you use the alveolar dead space fraction in informing vent titrations? And also, how would you sort of try to integrate that concept if you were using an oscillating vent?
Yeah. Again, fantastic questions. We are in a fortunate condition that we have volumetric capnography available in our ventilators, so we can breath by breath display the CO2 elimination. We can CO2 elimination per minute, and we can calculate the actual VDVT, which helps us in identifying the optimal level of PEEP. So when we do a PEEP titration, it's a combination of both the dead space indices, compliance, when patients are in pressure controlled ventilation, with the tidal volume. Those three mainly drive us in guiding our PEEP setting. There is one disclosure I have to mention. I am a high frequency aficionado, as some of you might know. So we have a really low threshold of going to the oscillator. So as soon as we think the patient the pressure is going up to 25, 28, and oxygenation becomes difficult and ventilation becomes difficult, we do calculate these things, but we put them on the oscillator. The drawback is then, of course, that we cannot calculate all those metrics anymore. So when we titrate our oscillator settings, the continuous descending pressure and the frequency, we rely on the saturation or the PaO2 and the PCO2. And then that space is really, really difficult to calculate. Now, for the AVDSF on conventional, the numbers are really small. I mean, you can see, read in the paper from Anubala what kind of cutoffs are for severe or non-severe. And they may help in some prognostication. As said, they are now currently trying to see if titrating interventions with this AVDSF calculation, well, if it's actually helpful. So that's some data that's coming out over the next few years.
Thank you, Dr. Martin. So we have another question in the chat. There will be falsely low AA gradient or even normal sometimes in an ABG sample if it has an air bubble mixed. Is there a way to differentiate air mixed from truly low alveolar to arterial gradients?
Yeah, that's a good question, because we do sometimes see that the blood gases are not drawn appropriately.
Yeah.
The honest answer is we discard them and do a new blood gas. That's the honest answer, because then we get the readings and we say, okay, this doesn't fit, and you can try to do some calculations. And you can say, okay, I'm going to try to see if I can adjust for it whatsoever, but I mean, it is still 0.2 ml blood. I understand it, but I mean, if the patient is really, really sick, I do want accurate readings.
So we go to the next question. In a patient with a low PO2, which one is the best or more efficient way to increase the PO2? Is it the PEEP versus FiO2?
First FiO2. I mean, that's the basic thing. It happens sometimes. We see it that basically, why is the PO2 increasing and then the FiO2 is still 0.3 or 0.4? So that's the first one. Increase the alveolar pressure of the O2, because you need a pressure gradient. And you can have a diffusion limitation, whatever, but you need to have a good, strong pressure gradient. That's how physics works. Then, if you are sure you're giving sufficient oxygen, then obviously you would have to make sure that the time to get the volume in is sufficient. You'll have an appropriate inspiratory time. If your inspiratory time is set too short, your tidal volume will probably be too low, and then there is no replenishment of refreshment of the gas. And if that is all fine, then the PEEP titration. Then try to maintain some degree or increase the end expiratory lung volume by a PEEP titration.
Okay, thank you, Dr. Martin. So the last question, I leave it to my colleague, Dr. Michael. The mic is yours for the last question.
Thank you. So what bedside pattern of ABG, end tidal, capnography, and pulse oximetry suggests shunt rather than hypoventilation or increased dead space?
I think if your PO2 starts to drop at the moment where you think, okay, I have a sufficient rate, I have sufficient oxygen in, then it's better dead space. Then it's probably shunt. So dead space ventilation, so there is ventilation, there's no perfusion. So at some point you see that the CO2 in the blood gas stays high, but your CO2 in your end tidal starts to drop because there's no more CO2 being released. That's the most fastest and cheapest way to discriminate between dead space ventilation and shunt. And if you try to decrease dead space ventilation, let's say if you have for example, they have a patient with a viral pneumonia, they have overdistended alveoli. You put your capnography on, and you see there's no CO2 coming out, or very little CO2 coming out. Because the airway is, and then you think, okay, let's increase some little bit of PEEP, or let's try to decrease. Let's say you have a PEEP of 10, and say, okay, because I had a PEEP of 10, and I think it's necessary to splint the airways. let's decrease the PEEP. And then if you decrease the PEEP, the hyperinflation is going to reduce. CO2 is going to increase in your end tidal tracings, and your perfusion is going to improve, and in the blood gas the same. It's the same, for example, with the oscillator, where you don't have end tidal CO2. It's a very common scenario. The patient is improving, and all of a sudden the CO2 in the blood is really, really high. And the first reaction of people would be either to change the frequency or would be to increase the pressure because the thing is lung collapse. And then when they call me, I tell them, first try to decrease the pressure. And why decrease the pressure? Just do it. Decrease the pressure. They decrease the pressure, and then all of a sudden, and then they called me back. Hey, they decreased the pressure. I drew a blood gas, and the patient has improved. CO2 elimination improved. Well, that's because of the improvement of the patient. The pressure, it gives overdistension. It compresses the capillaries. So you do have a lot of ventilation, but you don't have perfusion. And then by just decreasing your pressure, you decrease the degree of overdistension, and you improve the blood flow. So on conventional, bottom line, CO2 in the end tidal CO2 tracing really helps you to titrate your settings on that part.
Thank you very much. This had a second tag to this question, and it's a quick one. What do you think is more valuable at the bedside, pulse oximetry or capnography?
Capnography. Capnography. Definitely capnography.
I was betting on it. Thank you very much.
Thank you, Dr. Martin. Now we hand the mic to our colleague, Georgina. Georgina, you can close the session. The mic is all yours.
Thank you, Dr. Martin, for such an informative session. It was fantastic to have you with us for our first webinar, and who better to speak on this topic? You're a very good educator, very good at explaining such physiology. To our audience, thank you all for attending. Just a reminder that early bird registration is open for the WFPICCS World Congress, which is happening in Melbourne, Australia in September this year. And we look forward to welcoming you all in our second webinar on the 19th of February. We'll be joined by Dr. Briseda Mema from Sick Kids, and he'll be discussing When Blood Meets Air, VQ Mismatch and Shunt Mysteries, building on the foundations that Dr. Martin has given to us today. So we will see you all then.
Thank you very much.
Thank you.
Thanks, everyone.
Thank you, everyone. And as we see, we have the next session coming up next month. So please register and try and attend. It will be a great learning experience. Thank you, everyone.